In IVF, there are a lot of the controversies on many aspects keep going since years together. For example, ICSI for all or not, day 3 transfer or blastocyst transfer, freeze all or not, antagonist protocol or antagonist protocol for all or not. And the most of the time, the clinician, they are carried away by the senior people who are following some particular way of treatment blindly. Actually speaking, rather than following any treatment or any way of treatment by a senior person, you must look at the evidence and logic behind the treatment and then decide what suits you. So today we will discuss, should we promote blastocyst transfer for all or we should be selective, requires rethinking, because in most of the conferences everybody is talking about superb fantastic result of blastocyst transfer, but today we will examine what evidence says. One of the reasons for choosing extended culture up to blastocyst is considered to be a better option for the number of reasons. For example, it provides a better embryo endometrial synchrony and therefore the higher chances of implantation. It mimics more closely the sequence of events in natural conception. However, the ovarian stimulation during IVF leads to a supraphysiological level of estrogen and progesterone, which enhance the endometrial development. For example, the endometrium milieu at day 3 after the egg collection in stimulated cycle could be similar to the endometrial milieu on day 5 after ovulation in a natural cycle, owing to the effect of ovarian stimulation. The another reason is the selection of the embryo is better. Normally, the activation of the embryonic genome occurs at the 8 cell stage, that is stage day 3 embryo. It is believed that in the absence of activation, the embryo is unlikely to survive or implant. An obvious way to ensure this is to extend the duration of culture to a blastocyst stage, which will allow identification of the embryo that have managed to activate their embryonic genome. Logically, this looks good, but this is not necessarily the case, as in vitro survival does not equate to in vivo survival, which depends on the culture system used, that is, media, number and type of incubators, oxygen tension, etc. By committing to embryo transfer at blastocyst stage, there is a risk of losing some embryos which might not survive the challenges of extended culture but might have, if transferred to the uterus, survived in vivo, implanted and resulted in the pregnancy. Because ultimately, artificial is artificial and natural is natural. The blastocyst transfer improves the odds of transferring a viable embryo, but it does not guarantee euploidy. The morphological scoring, either at blastocyst or cleavage stage, is not an accurate way of identifying chromosomal abnormalities. And the recent studies have shown that the chromosomally abnormal embryos can become blastocyst. So, blastocyst does not guarantee a normal embryos. A meta-analysis of 12 randomized control trial showed a significant increase in live birth rate per started treatment when embryo transfer was carried out at blastocyst stage compared with cleavage stage. The another meta-analysis of 4 RCT which showed that the cumulative pregnancy rate. What is the meaning of cumulative pregnancy rate? That is number of births from one egg collection are significantly higher in embryo transfer carried out at cleavage stage compared to those at blastocyst stage. The possible reason for decreased cumulative live birth rate with the extended culture is that a number of embryos that do not reach blastocyst stage are discarded and not eligible for transfer. If these are frozen at cleavage stage and transferred after successful thawing, the pregnancy can be achieved. Many times, the extended culture is done for comprehensive chromosomal screening after day 5 biopsy. There are increasing evidence from RCT show that comprehensive chromosome screening at the blastocyst stage improves implantation and pregnancy rate. This, however, are yet to become incorporated in routine clinical practice, especially in the centers in the country like India, where it is governed by the lower economy. Economy is a very important aspect and constraint in offering the IVF treatment to the general population. There are two separate meta-analyses. They have confirmed that the IVF pregnancy resulting from embryo transfer at blastocyst stage were associated with a higher relative risk of preterm delivery and very preterm, that is less than 32 weeks delivery, compared to those resulting from transfer of cleavage stage embryo. So chances of preterm deliveries are high if the transfer is of blastocyst. The existing data suggests that increased chance of monozygotic twins associated with the blastocyst transfer. Data from the animal studies as well as now human studies also suggested that the extended culture leads to a large for gestational fetus. So that is another problem. A recent meta-analysis reported that the odds of congenital anomalies were significantly higher for the babies born after blastocyst stage compared with the transfer of cleavage stage embryo. The several reports they have shown that there is an altered sex ratio with the male to female ratio of 1.29. The reasons for adverse perinatal outcome after extended culture may be the extended culture may trigger a genetic and epigenetic changes in the trophodermal cells that can lead to abnormal placentation and implantation, and hence the increase in the risk of preterm delivery. Despite the concerns highlighted just now, the extending culture to a blastocyst stage seems to be preferred strategy among many IVF clinics, and its popularity has grown exponentially in recent years. Because everybody believes that blasts are good quality embryo and they are going to give higher success rate. Although we go to extreme lengths to select the best embryo, the current tests of embryo quality lack the precision, and pregnancy can arise from non top quality embryos as well as those which never make it to a blastocyst stage. The extended culture in the woman with very few embryos incurs the risk of either having no embryos for transfer in a fresh cycle or cryopreservation for future use. Hence, we do need to consider the alternative strategy in our clinic. Whenever supernumerary embryos we get, we try to transfer fresh provided the endometrium is triple lined, the progesterone is not elevated. So we try to transfer good quality embryo in the fresh cycle provided the environment is good. If progesterone level is elevated or if there is a hyperstimulation and if we decide to freeze the embryos, we normally freeze the embryo on the cleavage stage. All grade 1 embryos are frozen, or maybe some of the grade 2 embryo. All rest grade 2 embryo and grade 3 embryo we keep for the extended culture. So, after the extended culture, whatever embryos they form a blastocyst, we freeze the blastocyst after extending the culture of grade 2 or grade 3 embryo, which can be utilized later on and likely to give a better result later on. The another question many times asked whether the blastocyst should be frozen on day 5 or day 6. It has been concluded by a study that the clinical pregnancy rate following frozen embryo transfer is significantly lower with the blastocyst vitrified on day 6 compared to a blastocyst vitrified on day 5. Another question asked, suppose we have frozen vitrified the blast on day 5 and some of the blast we have vitrified on day 6. When it should be thawed and when it should be transferred? The answer is the embryos vitrified on the day 5 should be thawed on day 5th of progesterone and transfer after 20 to 24 hours. Whereas the embryos vitrified on day 6 should be thawed on day 6 of the progesterone and transferred after 2 to 4 hours of culture.